bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, Associate Director at CAFC, the Canadian Association of Pediatric Health Centers. And today we're going to be talking about going from vaccine hesitancy to vaccine resilience, building and sustaining vaccination acceptance and uptake. And it's my pleasure to welcome Dr. Yves Dubé to today's presentation. We've had lots of interest over the past, for many years around vaccination and immunization, and in particular over the last few years with the concerning trends around vaccine hesitancy and some of the outbreaks we're now seeing. I saw and people not recognizing the importance of vaccine as a public health initiative. I saw a tweet from the Saskatoon Health Region today just acknowledging Vaccine and Immunization Awareness Week, recognizing that 100 years ago infectious diseases was the most common cause of death in children, and today it's less than 5% of children die of deaths are from infectious diseases. So, and most of that is as a result of vaccine and immunization. So it's really an important topic. We've done many presentations. We had Dr. Marina Salvadori come and join us from London Health Sciences Centre to talk about the role of the acute care centres and children's hospitals and rehab centres working with the disabilities population and how they have an important role in vaccine and immunization awareness. And today we're going to be talking about vaccine hesitancy, which we've talked about before, but again, bringing it to this new relatively new concept of vaccine resilience. So it's my pleasure to, as I said, welcome Dr. Yves Dubé, who is a medical anthropologist working at the Quebec National Institute of Public Health. She's also a researcher at the Research Center of the CHU-Quebec, and she's also a professor in the Department of Anthropology at Laval University. So it's my pleasure to hand the virtual podium over to you, Dr. Dubé.
Merci beaucoup. Thank you very much. I'm very pleased to present you today on this topic, given that it's the National Immunization Awareness Week. So just moving my slide. Oh. Okay. It's working. Okay, so the objective of my talk today is to give you a broad overview of what is vaccine hesitancy and what it looks like in Canada, and then I'll discuss some potential causes of vaccine hesitancy and solutions to address this issue. So we will also look at vaccine hesitancy among healthcare providers, and I'll conclude by introducing a new concept, the concept of vaccination resilience, which is talking about the importance of building and sustaining vaccine acceptance. So as you might all be aware, vaccination is considered as a public health success, and it's estimated that vaccines save 2 to 3 million deaths each year. However, since the very first smallpox vaccination program, people have been reluctant to receive vaccination, and vaccine hesitancy can affect any vaccination program. It has been associated with outbreak of many diseases in different countries, such as pertussis in the UK and Japan, polio in Nigeria, and measles in the US and Canada. Maybe some of you will remember that in 2015, we saw a larger outbreak of measles that were linked to an outbreak in Disneyland. So here in Quebec, we got almost 100 cases of measles among a community that refused all vaccines. So this clearly is and showing the dramatic impact of vaccine hesitancy that could have on health. So vaccine hesitancy is also a weak public health issue. It's a thorny issue that is difficult to resolve. The use of the term weak here is come to denote resistant to resolution rather than evil. A weak issue is a problem that is difficult or impossible to solve because of contradictory and changing requirements that are often difficult to recognize. It's also used to refer to the fact that effort to solve one aspect of a weak problem may create other problems. So the term weak was originally used in social planning in the 1970s. Other examples of weak problems include global warming, AIDS, or drug trafficking. So weak issues share common characteristics, including the fact that there's no unique or correct definition or view of the problem, and that the potential solution to the problem depend on the definition. So data around the issue are often uncertain or missing. There's conflicting value at stake, and there's no good or right solution to a weak problem. So weak issues are really persistent and hard to resolve because they do not lend themselves to a scientific consensus about the source of the problem and the best means to resolve it. So vaccines, there's a broad scientific and medical consensus around the importance and benefits of childhood vaccination, but there's no such agreement on what is exactly vaccine hesitancy, and there's no effective, unique solution to address this issue. So this is a citation by Dr. Margaret Chan, who was at that time the Director General of the World Health Organization. She was speaking around the H1N1 pandemic influenza mass vaccination campaign, and this campaign has been facing different issues in different parts of the world. She was saying that the days when health officials could issue advice based on the very best medical and scientific data and expect population to comply may be fading. So for most social scientists, this might seem obvious, but the lack of acceptance of health authorities' recommendation by the public appears to be something new to many public health experts. So vaccine acceptance cannot be taken for granted. That always never been the case, but there's some indication that the situation might becoming worse. So what is exactly vaccine hesitancy? When we look at vaccine coverage surveys and other studies conducted in Canada, we can have a broad idea of what the situation looks like. So at one end of the continuum, we have people, the majority of people who do accept vaccines. So there's 75 to 80% of parents, for instance, do that follow the recommended vaccine schedule. Most of these parents do trust the vaccine to be safe and effective, and do consider that vaccination is beneficial and important. They're often have trust in their healthcare provider, and they are influenced by social norms. At the other end of the spectrum, we have a tiny minority of people, less than 2%, will refuse all vaccines. These people are often strong-willed and committed against vaccination. They often have specific religious values or a different vision of health. And in the middle of these two groups are the vaccine hesitant. Between 25 to 30% of parents can be considered as vaccine hesitant. Among these parents, some may delay vaccination, or they may refuse one, two, or different vaccines. These parents have significant doubts on the safety and usefulness of vaccine. They are actively seeking information. They don't know who to trust. And we know that many of these parents have within their social network other parents who are anti-vaccine or vaccine refuser, and can negatively influence them. So really, vaccine hesitancy is defined by WHO as lack of acceptance when vaccination services are available. It's really to reflect those people in the middle of the continuum of vaccination attitude that might refuse all vaccine but be unsure about their decision. They may accept all vaccine but still have important doubts and concerns, or refuse some vaccine and accept others, or delay vaccination. So outside of the scope of vaccine hesitancy are those people with strong anti-vaccination belief, because they're having a very different worldview and different conception of health. Outside the scope of vaccine hesitancy are also those people who will not be able to accept or refuse a vaccine because they are not aware that a vaccine is due, or because they have issues in accessing the vaccination services, for instance. And vaccine hesitancy is also different than vaccine demand if we define demand as individuals and communities who understand the values of vaccine, and demand immunization as both the right and responsibility. This is a step further than vaccine acceptance, and it's outside the scope of vaccine hesitancy. So vaccine hesitancy has always existed, but there's a perception that vaccine hesitancy has been on the rise in recent years. So what are the causes of vaccine hesitancy? The WHO Working Group on Vaccine Hesitancy has summarized the determinant of vaccine hesitancy into a simple model called the 3 C's. So I will go through these three big group of determinants in the next slide. So complacency, it's defined in the dictionary as self-satisfaction, especially when accompanied by unawareness of actual dangers. If we apply this definition to vaccination, it could reflect the fact that other life or else responsibility are perceived as more important than to vaccinate. For instance, we know how busy is the life of parents with young children, especially if there's more than one child in the family. And going to an extra visit to the clinic for vaccine might be simply too complicated for someone who is not highly motivated about vaccine. Complacency can also reflect not just lack of motivation, but also a feeling of not being able or not knowing how or what to do to get the vaccination done. Applied to vaccination, complacency also refers to the fact that people might come to think that vaccines are not needed because they perceive the risk of disease as low or inexistent. In fact, we often hear that vaccines are victims of their own success because we don't see a lot of the disease against which we vaccinate. People are now more focused toward the risk of the vaccine than the risk of the disease. So I've put the slide that was developed by Robert Chen from the CDC in the United States, showing in theory how this is playing out. So at the beginning, before the vaccine, the incidence of a specific disease is high and people are afraid, as it was the case, for instance, in polio in the 1950s, as shown by this other picture of the iron lungs that were used to treat people with polio. So at that time, there were many cases of polio circulating, and people were really afraid. My grandmother used to tell me that when the first vaccines were made available, she literally put all her child in the car to rush to get them vaccinated because she was seeing children dying all over around her. To get back to the slide, so when there's no vaccine and a lot of cases of disease, people are afraid. And then the vaccine is introduced. Vaccine coverage slowly increase. With more and more people receiving the vaccine, the incidence of the disease decrease, and the number of adverse events increase, leading to a new perception of the risk associated with the vaccine. And then if people stop getting vaccinated, we could see outbreaks of the disease, which could again change the perception of risk perception toward accepting vaccination. The other group of determinant of vaccine hesitancy is confidence. We can define confidence as having trust in healthcare professionals who recommend and administer the vaccine. Confidence is also used to refer to confidence in the vaccine themselves and the system that monitor vaccine safety, as well as general trust in institution or trust in the motivation of the policymakers who decide which vaccines are needed and when. So here I'm showing you some result of a recent survey we done with Canadian parents. So we have surveyed a little more than 2,000 parents of children aged between 2 and 5. Most of these parents said that their child has received all recommended vaccine at age 2, and only 2.2% said that their child was completely unvaccinated, which is close to what we could expect to find in the general population of parents in Canada. So in this slide, we can see that parents have generally an high level of trust in doctors to do what's in the best interest of the public. They also trust public health authorities and academic researchers to do what's in the best interest of the public. However, only 45% of the parents trust the government to do what's in the best interest of the public, and less than 30% of the parents trust media to report fairly and accurately about health questions, and trust that the pharmaceutical industry is doing what's in the best interest of the public. Most interestingly, in this slide, we can see the same question, but we split parents in two groups. So in dark purples, it's the parent who intend to get their child vaccinated in the future, and in light purple, it's parents who are unlikely or unsure about getting their child vaccinated in the future. So we can see that trust in doctors remains high for both the vaccine hesitant and the non-vaccine hesitant parent, if we define vaccine hesitant in this case as those who don't intend to vaccinate. While trust in the media and the pharmaceutical industry remain low for both groups. But it's interesting to note that there's significant difference between vaccine hesitant and non-vaccine hesitant parents regarding trust in public health and academic researchers, with vaccine hesitant having much less trust in these two groups than the parents who are likely to vaccinate in the future. Finally, the last group of determinant is convenience. Convenience here refers to the quality of the service, real or perceived, and the degree to which vaccination services are delivered at a time and place and in a cultural context that is convenient and comfortable. This must not be understood as availability of vaccine or vaccination service, but it's more about the perception of the person regarding the service. For instance, convenience is a factor leading to vaccine hesitancy. If the vaccine provider has been rude to me, then this could be making me hesitant. If I need to take off work to have my kids vaccinated at 18 months because the vaccine are only administered between noon and 3 o'clock, for instance, this could also affect my willingness to come to receive the vaccine. So a quick note just to say that although this simple model put the determinant in different boxes, in real life it's much more complicated than that, and we often see a different determinant that are interrelated and that can lead to vaccine hesitancy, and it's more, life is more than a mess than this simple model. So just to sum up to this point, vaccine hesitancy is complex, it's multidimensional, it can affect all vaccine and all vaccination program. vaccine hesitancy exists among the public, but it also exists among healthcare providers, and I'll speak about that in a few minutes. Vaccine hesitancy has always existed, but some factors in the actual context can increase vaccine hesitancy. There's been a substantial increase in the number of vaccines introduced in recommended schedule. Some of these vaccines are against diseases that are perceived as mild. For instance, the rotavirus vaccine against gastroenteritis or the varicella vaccines against chickenpox. This could bias risk perception and increase vaccine hesitancy. There's also a decline in the prevalence of many vaccine-preventable diseases, which could lead to an increased focus on the safety and usefulness of the vaccine. There's also a decline of trust in science and other institutions, and many conflicting information about vaccines that circulates in internet and social media. This is a frequent causes of vaccine hesitancy. What people see in the internet is often stated as a reason why parents hesitate to receive vaccine. So what can we do to address vaccine hesitancy? As I was saying earlier, vaccine hesitancy is a weak public health issue as we don't know what's working best to address it. So this is a paper that we've done looking at the literature on strategies to deal with vaccine hesitancy. What we have found is that there's no magic bullet solution to address this issue. Most of the published studies were measuring impact on vaccine intention or vaccine uptake, not especially about vaccine hesitancy. If a person is really hesitant, maybe a strategy can be or an intervention could be effective in moving this person toward vaccine acceptance, but we cannot expect that this person will give the vaccine, for instance. So it's hard to measure the effectiveness of strategy using traditional approach. So what we usually do in public health when we are faced with vaccine hesitancy, we usually try to inform and educate. So we give more facts about vaccines, we give more facts about vaccine preventable diseases. Sometimes we try to fear people into accepting vaccines. Unfortunately, once a belief is formed, it's very difficult to shift it, and worse, messaging too strongly against a person's initial belief, it may in fact reinforce this belief, and I'll come back to this in a few minutes. So this is a model that we often use in studies and in public health to design our intervention when we're trying to promote vaccine acceptance or address vaccine hesitancy. So according to this model, the likelihood of getting a vaccine is influenced by different factors. For instance, we have the perceived susceptibility to vaccine preventable disease. So am I at risk of catching a disease? And the perceived severity of vaccine preventable disease. Will it be serious if I catch this disease? That will influence or lead to perceived treat of a disease. The more the treat is important, the more likely we will be to get the vaccine. Other influence are perceived benefits and barriers of vaccination. Do I think this vaccine is effective? Do I think it is safe? And cues to action. Cues to action refers to receiving a recommendation by our healthcare providers about the vaccination, or knowing someone who was affected by that specific disease. So all this put together will lead a person to accept the vaccine or not. So according to this model, people do do balance pros and cons, do get information and facts, do an objective analysis, and make a rational decision. For medical scientists or for public health specialists, the rational decision in this case is to accept vaccine, because of course we know that the likelihood of adverse events is really, really small, and the potential benefits of vaccination really, really high or important. However, when we look at how the choice people make, the decisions are much more linked with how people feel about the facts than about the facts themselves, even if people do correctly understand these facts. What we see is that most of the time we take a decision based on our pre-existing values, emotion, and perception, and then we look for facts that confirm that we have made the right decision. So emotion, much more than rationality, drives risk perception. For instance, risk to children feel more serious than risk to adults because children are vulnerable. Risk from the vaccine feel more real because they seem more proximate than the actual disease that is being prevented. So our emotion play in our perception, even when we look at number. For instance, research have shown that frequency formats, for instance, 1 out of 10 infants will have fever after the vaccination. This feels more risky than the same information when it's phrased in probability terms. For instance, 10% of infants will have fever after vaccination. 1 in 10 feel more real than 10%. So we know that we all use, expert as lay public, different mechanisms to make decisions. These mechanisms are called heuristics. So it's intuitive, automatic, and often unconscious shortcuts that we all use when we need to make a decision quick. So two examples of common heuristics that play in vaccination decision. The first is the coincidence dragoon. Could be defined as making causal association when there's only temporal association. So it's the belief that everything that happens after a vaccine is assumed to be caused by the vaccines. So we see that often in anti-vaccine websites, for instance, parents saying that their child was perfectly fine before he received the vaccine, and then he received the vaccine and everything goes wrong. And there's a powerful anecdote about that is from Paul Lafitte. Paul Lafitte is really I guess most of you know Paul Lafitte is the inventor of the rotavirus vaccine, is a prominent physician that speaks for vaccine in the States. So Paul Lafitte was saying that there was a patient in his office and he was getting ready for the needle, preparing the injection. The nurse was preparing the injection, and just before the vaccine was given, this child got convulsion and lost consciousness. The child was afterwards diagnosed with epilepsy, but what would happen if this loss of consciousness was had happened just after the vaccine? That those parents would have been convinced that it was due to the vaccine. So the second heuristic is the availability bias. So it's the tendency to judge that something is bad is more likely to happen if we can recall it easily. So people can perceive that vaccinating is more risky than not vaccinating because they've seen a lot of stuff around adverse events, but not much about the disease that vaccine prevent. So many people don't know what's diphtheria, that haven't ever heard of a polio, and what we see is often cases of mild disease, but like measles, and so that could affect vaccination decision. So there's a clear need to have good strategies to address vaccine hesitancy. However, there's less clear ways on how to do this. Today, there's no consensus on how best to use communication to respond to vaccine hesitancy. And what we know from the research is that simply giving people more information about vaccine risk and benefits is often unsuccessful. Of course, information is needed. Parents need to have facts and be informed about vaccination. It's an important first step in taking a decision. But information and education alone are not sufficient to make a vaccine hesitant parent move to accept the vaccination. We also need to be careful with fear. Pro-vaccine messages do not always work as intended. So this is a picture that was used in a popular study conducted by Brendan Nyand in the United States. So in this study, they've tested different material that are used by the CDC to promote vaccination against measles. So this is a photo of a child with measles, and parents, vaccine hesitant parents were shown this picture. So it did increase their awareness of the risk of measles, but instead of increasing their intention to vaccinate, in fact, it decreased their intention. So this is the backfire effect. So we need to know stuff, but knowing stuff is not enough to doing things. So many of us know that we should do 30 minutes of physical exercise each morning to be healthy, but many of us have different, me included, have different reasons to skip the exercise each morning. So this is the no-do gap. So in this context, we know that one of the most powerful drivers of vaccine acceptance, or the most effective strategies to address vaccine hesitancy, is the recommendation from healthcare providers. So this is one of the main reasons why vaccine hesitant parents finally change their mind and accept vaccination. Many studies have shown this clear association, and research also indicate that healthcare providers are the most trusted source of information about vaccination. At the same time, some healthcare providers may underestimate their influence. They may have limited time to discuss vaccination with their patient, and they could also use inappropriate communication strategies to address vaccine hesitancy. But even worse, some studies have shown that healthcare providers can be vaccine hesitant themselves, so unlikely to address their patient hesitancy. So there's a clear association between healthcare providers' own vaccination behaviors and the recommendation to their patient. Providers who receive a given vaccine are much more likely to recommend this vaccine to their patient. And what research showed also regarding vaccine hesitancy among providers is that factors leading to vaccine hesitancy are, like in the population, are highly context-specific, complex, and multidimensional. But healthcare providers' attitudes about vaccines can be pretty similar to what we can find in the general population. For instance, providers may distrust health authorities just as the population does. So this slide shows you a result of a qualitative study that was done with healthcare providers working in 4 countries in Europe. These were mostly nurses and physicians, and as we can see, their concerns are pretty similar to what we could expect to find in a population of parents, for instance. Many believe that vaccines are not needed because the disease no longer exists or there's a very low chance of getting them. Many were concerned about side effects and safety of vaccine. Some thought that diseases are beneficial for the immune system. And pretty specific to the providers, many were uncomfortable talking to their patient about their concerns about vaccination. Others believe that there was too many vaccines or mistrust the pharmaceutical industry. So this is a table from a study that we've conducted among frontline vaccine providers in Canada. It shows that the level of trust in findings about vaccine is very high when the research is funded by the government or by academic institution, but from 15 to 28% of providers do not trust findings when the research is funded by the industry, even when it's in partnership with academic institutions. So this is of particular concern because we know that most research around vaccine safety and efficacy are costly because we need a large number of participants, and most of these research are funded by the industry in partnership with academic institutions. So if providers do not trust these results, then we're facing important difficulties. So now moving to the last part of my presentation, what I hope that you will remember is that what we are facing in Canada is mostly a problem of vaccine hesitancy rather than vaccine refusal. When vaccine make headlines, the portrait is often kind of negative and the emphasis is put on the anti-vaxxers, but this represents only a tiny minority of people in Canada. Meanwhile, the majority of people do accept vaccines. So it's the people with question about vaccination, the vaccine hesitant, that we need to understand. And these people are not wrong, dumb, or selfish. Most of them are well-meaning people that just try to do what's the best for their families. And if we look at the vaccine hesitancy continuum, we know that what works with one group might not work with another one. And another important thing that we must not forget is to ensure that the decision to accept vaccine of the majority must be supported and valued. So this brings me to the concept of vaccination resilience. So in psychology, resilience refers to the individual capacity to positively cope with significant adversity. And this concept has also been applied to vaccination programs. So in that case, vaccination programs that are resilient are programs that are able to withstand major shock and disruption, to quickly adapt to changing circumstances, and to maintain high vaccine uptake and acceptance over time. So vaccination resilience is more than the sum of individuals' own vaccination resilience, but also include social networks, organizations, formal institutions, and broader health and political systems. So it's important to enhance vaccination resilience, as immunization program can rapidly be derailed when safety concerns arise and are hyped by anti-vaccine rhetoric. So in Quebec, vaccine hesitancy was not a major issue at the time of the HPV vaccination program introduced. And in the first year of the school-based program, an uptake of around 80% was reached for the first year. But since the introduction, the vaccine was the object of frequent negative claim in popular media, which has led to a constant decrease in vaccine uptake. In fall of 2015, there was a publication by McGill researcher in the newspaper Le Devoir that was these researchers were requesting a moratorium on the HPV program, and this has made a huge backlash on the program. Many parents, this was published at the time of the consent was reached in schools, so many parents who at first consented to have their child vaccinated then choose to withdraw their consent. In some schools, it was almost half of the parents who did so. And many school nurses felt that they were not receiving the adequate support from public health authorities and didn't know how to manage this controversy. So I don't know about the impact of the Toronto Star paper on HPV vaccine in English Canada, but this media controversy in Quebec did have a significant impact on our uptake rate in Quebec. And not to get you too depressed, but needless to say that when it's the President of the United States that make a statement linking vaccine to autism, the potential impact, negative impact, can be important. So when we look at the HPV controversy in Quebec or the false association between the measles, mumps, and rubella vaccine and autism that occur in the UK with Andrew Wakefield, what we can see is social contagion of vaccine concerns. So vaccine concern can spread in social networks much like disease do. So while the majority of parents choose to vaccinate their children, most of them do not speak publicly about their decision, which means less social contagion for positive behavior, but much more social contagion for negative behavior. So anti-vaccine stands are often presented as being endorsed by much more people than they really are. So the role of social norm and social networks must not be underestimated. Most parents ask advice or listen to their spouse, friends, or family's member when they make decisions about vaccines. They can also be influenced by celebrities in the media speaking about vaccine. And this is a result of a study done in the United States showing that the percentage of a parent's network member that were vaccine hesitant or anti-vaccine was more predictive of the decision of a parent to vaccinate or not than any other variable, including the parent's own perception of vaccination. So this is pretty strong. So to conclude, some promising avenue on how to address vaccine hesitancy and AIDS vaccination resilience. Although this concept is relatively new in the public health discourse around vaccine acceptance, resilience has been widely used to inform public health strategies for emergencies and disease preparedness. So building on this body of work, I will conclude by talking about some strategy that we could adapt for vaccination. So as I was saying, we know that information alone is not effective to address vaccine hesitancy or increase vaccine acceptance. Worse, we know that trying to correct false belief of people who have less pro-vaccine attitude can in fact work exactly as the opposite and strengthen their negative belief. So we need to move beyond this knowledge deficit model and develop other approach to use to shift the negative vaccination discourses and support vaccination resilience. We also need to develop effective communication strategy and leverage existing information channels in order to ensure that we listen to the specific concern of different communities and that we tailor our intervention. So promoting HPV vaccine acceptance in school-based program in Quebec after this media crisis is not the same than trying to promote vaccine against measles in an anti-vaccine community after the measles outbreak, for instance. So changing risk perception through communication means that we need to tailor messages and take into account the specific realities of communities. We also need to make sure that the voice of people we immunize is heard, and on that there's a very interesting intervention that is that started by Immunize BC, that's called iBoost Immunity. So the website can be easily found on the internet, and it's really to promote the pro-vaccine discourses in the population. Vaccination acceptance also relies heavily on trust. So we need to apply trust-building strategy to ensure transparency around how vaccines are manufactured, homologated for use, including publicly funded programs, and monitored for safety and effectiveness. There are rigorous mechanisms, for instance, in Canada and worldwide to monitor vaccine safety, but most people in the population are not aware of how this is working and the strength of this vaccine safety system. So to have long-term trust in vaccination, people need benefit and risk information that is easy to understand and empowering them to make informed health decisions. And in that context, healthcare providers have a key role to play. Finally, we need to positively value and acknowledge that those who accept vaccination and demand access to vaccine by saying that they not only protect themselves but also their community. Most people in Canada still do accept vaccination, and this needs to be reinforced as the social norm. So in that sense, appealing to social identity by pointing out that most others do a behavior could be effective. Research has shown, for instance, that people are more likely to reuse their towels in hotels when the little note don't just say please reuse your towel to protect the environment, but when the notes say most people do reuse their towel, so people are more prone to reuse it. So this could be an effective strategy that we could use to influence decisions. So that's it for my talk today. Will be more than happy to have your comments and questions.
All right. Thank you, Dr. Dubé. A great presentation, always a timely topic, especially as you pointed out with issues happening south of the border and some of the comments coming from very important people down there around vaccine and the links with autism and all that. So it's definitely a timely issue once again, unfortunately. So this is your chance as the audience to ask your question. Please do type them into the question box. The first question that came in was sort of in relation to some of the strategies that you were laying out at the end there. Knowing that more knowledge, you said right at the beginning of the presentation, just providing more knowledge is not the solution. That generally doesn't work. But Aaron's asking if there's a difference between strategies for addressing vaccine hesitancy between healthcare practitioners and those healthcare providers that are hesitant versus members of the general population that are hesitant, both having different levels of knowledge and trust with the healthcare system, et cetera. So can you identify any strategies that might be a little different when you're trying to address that hesitancy with healthcare providers?
So what we see with healthcare providers is exactly the opposite that in the population. So in fact, more knowledge is empowering providers to be less vaccine hesitant. We see it among nurses, for instance, in Quebec. So nurses who vaccinate, who give the vaccine, are more likely to have continuous training about vaccination, and they do have more positive attitudes toward vaccines than nurses, for instance, who work in emergency care and do not vaccinate on a regularly basis, or are less likely to receive information and training on the topic. That being said, we've seen that providers can believe in the same myth than the public do. For instance, there's a studies conducted in French among physicians showing that almost 1/4 of the physicians believe in the false association between hepatitis B and multiple sclerosis, which is a concern that is particularly salient in France. But then it's quite shocking to see that the people with medical training could have shared these type of belief. So training, yes, but we need to also apply the same communication strategy, appealing to emotion, trying to use narrative, and we need to evaluate what we are doing to make sure that it's working as intended.
So I did. I just received a question in French that I'm going to actually forward on to you. Actually, I'm going to ask Anne if she can do that, because unfortunately I am not. I don't speak French, so we'll forward it on to you, and you'll see it in your little question box. Perhaps you could read it for the audience, and.
Okay, so where is it supposed to? Okay, I see it. So it's about people who start vaccinating but don't give one dose of a vaccine, but don't give the subsequent doses, but there don't seem to have. It's more a comment than a question. So it's saying that people start the vaccination but don't finish the doses, and of course this could be for different reasons. So we could see that. Some people don't know that there's a subsequent doses to be given, or people for a young infant can start going back to work and then have difficulties in going to the vaccination services. And there's also the fact that some parents are really hesitant to vaccinate and then go to the clinic, have the first shot, and then see something happen within their child, and this could be linked to the vaccination.
All right. So I think we do have time for maybe one more question. We are just about out of time here, so we'll let the audience, if you do have any last-minute questions coming in. One other question is the role of media. What would you suggest has been the issue with media, as far as, is it about lack of their ability to interpret accurate information, or is it just the fact that they are presenting sort of the negative cases instead of the positive cases, of which, sort of what makes good news, as far as what they're willing to publish? I mean, what's the role? Oh, she says, sorry, Dr. Dubé says she accidentally disconnected herself. So hopefully she will dial back in. We'll give her a second to just dial back in. And if we can't get her back in, we may wrap this up just a minute early.
Hello.
Hello. Yes, you.
I'm sorry. Would have been too good if there was no technical problem.
Yeah, that's all right. I think we did catch the end of your last response, but if there was anything else that we didn't catch, let us know.
Yeah, just saying that it's really difficult to tell what's happening when we only look at vaccine coverage data. So we need to really speak with these people to see if it's awareness or if it's a concern regarding adverse events that make these people stop the vaccination.
Yeah. All right. And the last question I was just asking when I realized you weren't there was related to the role of media, and just wondering if it's more of an issue of their sort of over-publication or over-emphasis on the negative cases because it makes good news, or is it as much a part of their inability to interpret the science in an appropriate way, like a difficulty in sort of reporting on sort of complicated scientific matters? What would you say is the role of the media in sort of enhancing this problem?
Clearly, there's an important role. There's many research that shown that controversy in the media has an impact, has a concrete impact on vaccine uptake rate. We see all these questions regarding false balance. So journalists usually try to present both sides of a question, and they could have a public health expert speaking in favor of vaccine, and then someone, an homeopath with no training on the question, speaking against vaccine, and both sides are presented as equal side or both accepted side of the question. However, I must say that since the Disneyland outbreak, we've seen a shift in the media discourse around vaccine in general, and we felt that the discourse is much more pro-vaccine, presenting the public health opinion, and even maybe a bit too harsh on the vaccine hesitant people. So we've seen some editorials that were pretty rude towards people refusing vaccines, saying that these people are dumb or selfish or don't understand science. And of course, it's complicated, and scientists or public health experts are not always trained to speak to media, and their answers could be quite complex and not appealing and not formatted in the 30-second quotes that media are looking for. So it's a complex question.
Mm-hmm. So just before we wrap up, maybe we'll just get you to sort of think about any closing comments or final sort of messages you'd like to leave the audience with. But I'd just like maybe to get your thoughts on one last thing, just knowing that many of the members of the audience today are from sort of acute care hospitals or children's hospitals. Not everyone, but a lot of the audience is. And you've talked about trust as being a big component of addressing this, along with knowledge and other things, but really building trust with the healthcare system and healthcare providers, et cetera. And just acknowledging that, for example, the Children's Hospital of Eastern Ontario, CHU, in Ottawa here, created their own vaccination campaign where they had a website and a social media campaign, et cetera, that was quite successful. And I think the thought was that it was very successful because children's hospitals in general, and CHU in particular in Ottawa, have such a good reputation within the community, have such a trusted reputation and recognized brand. And when they throw their name of the children's hospital behind an initiative such as a vaccination campaign, it really has a lot of weight. So I'm just wondering if you had any thoughts about sort of a message going forward for those in the audience here about what could the continuing role of the acute care centers, the children's hospitals, the children's rehabilitation centers even in addressing this? What can their role be?
As you say, when you are already a trusted institution, your role could be tremendous. I understand that these institutions cannot be promoting every public health question or every public health aspect, but when a trusted institution step beyond another campaign, it's really powerful. And trust, it's really complex to build, and it's depending on many different things. And once you lost trust, it's really difficult to regain. So we see as public health is embedded within government, we see some scandals around corruption, especially in Quebec, but some corruption in the government that kind of affect the public health authorities. So often we need to get the message through other trusted institutions such as acute care hospitals. And every people working within this institution are some promoters of vaccine, and even if they're not vaccinating people themselves, they can always answer questions of their patient. And if they say that they do vaccinate or that they have their kids vaccinated, then it's a powerful message, stronger than any public health mass campaign can do.
All right. So I think with that we will wrap up, and we'll just hand the microphone one last time. Back to you, just to any closing key messages you'd like to send the audience off with before we wrap this up.
As I was saying, as healthcare providers, you have a tremendous role to play in promoting vaccine acceptance, increasing vaccine resiliency. So I strongly encourage you to have your own stories. We all have stories about diseases and vaccines. My uncle has had polio as a child. This is a powerful story that I use to speak about vaccine. I guess you all have your own stories, and I encourage you to share it with people around you to promote vaccination.
All right. Thank you very much. Great presentation. As we said, timely topic and very relevant, especially given it's Vaccine Awareness and Immunization Awareness Week. So it's great to keep it top of mind for everyone. So thank you for joining us today and giving such a great presentation.
Merci beaucoup.
We do our webinars every Wednesday at 11 a.m. Eastern Time, so it's great when you can watch live, as these questions really do enrich the discussion, and it gives you a chance to sort of contribute to the conversation. But when you can't watch live, we do record these sessions and make them available after the fact, and we will also make the PowerPoint slides available on the Knowledge Exchange Network as well afterwards. Next week on May 3rd, we will hear about some recently developed Canadian pediatric nursing standards, ensuring high-quality nursing care for children across Canada, and we will be welcoming Bonnie Fleming-Carroll from the Hospital for Sick Children in Toronto. Participants will learn about the unique Canadian pediatric context of the pediatric nursing standards, the development of the development process of the Canadian-specific pediatric nursing standards, and the potential impact on nursing practice, education, and research. And then following that, on May 10th, we will talk about lessons learned from the It Doesn't Have to Hurt Science Media Partnership that we've heard about before, where we will be welcoming back Dr. Christine Chambers and Erica M. from the Yummy Mummy Club to talk about the It Doesn't Have to Hurt initiative. And they joined us a number of months ago, so you can certainly see that presentation on the Knowledge Exchange Network where they talked about the program, but they're going to be coming back because the project is wrapping up, the research component is wrapping up. They're going to be sharing some final analysis and some of the numbers that demonstrated the impact of that work, and certainly relevant to this topic around vaccination, and potentially a model, a knowledge translation model to engage parents and children about vaccination. Certainly some lessons to be learned there. And they're also going to be joined by Isabel Jordan, who's a family representative that participated in that work, and Isabel is going to talk about the value of this initiative in identifying a role for parents in helping to shape knowledge translation interventions, and the need to engage partners with expertise in communicating and reaching parents to help ensure that research evidence about children's health actually reaches end users. So I think that's for this audience that participated today, I think that certainly could be a very interesting topic, as the lessons learned there would certainly apply to the vaccination and immunization world. So some great stuff coming up next week. Thanks again to Dr. Dubé, and thanks again to the audience for joining us today, and we hope to see you back here next week. Bye, everyone.